So, good evening, everyone. Today, I will be discussing Pharmacology Rapid Revision Part 1. It includes General Pharmacology and Autacoids. So, let's start. First topic will take it distribution of the drug and the plasma protein binding. So, first topic is apparent volume of distribution. So, it's a total amount of drug in the body upon the concentration of the drug in the plasma. Now, the concept is if volume of distribution is low, then most of the drug will be present in the plasma only. If the volume of distribution is high, maximum drug is present in the tissues. For example, chloroquine. So chloroquine has a highest volume of distribution, which is 1300 liters. So there is very high risk of toxicity when there is intake of chloroquine on a long-term basis. Now we'll talk about loading dose and maintenance dose. Loading dose, the formula is volume of distribution multiplied by plasma concentration. So loading dose depends on the volume of distribution, while maintenance dose depends on the clearance. That's clearance multiplied by plasma concentration. So there is an important concept. In a renal or a liver disease patient, loading dose remains constant. Maintenance dose should be decreased. So whenever we are planning to give any drug to the patient of a renal or a liver disease, loading dose remains constant, while maintenance dose should be decreased. Next topic is plasma protein binding. Now acidic drugs binds to albumin and basic drugs bind to alpha-1 acid glycoprotein. So there is a mnemonic that A for A, right? So acidic drugs bind to albumin. For example, drugs which are binding to albumin are all the acidic drugs, which include barbiturates, benzodiazepines, non-steroidal anti-inflammatory drugs, and phenytoin. So drugs which are binding to alpha-1 acid glycoprotein are beta blockers, methadone, verapamil, calcium channel blocker, which are all basic drugs. Next topic is dialysis and the drugs. There are two prerequisites that the drug must follow for a dialysis. Plasma protein binding should be low, and the volume of distribution should also be low. So there are some drugs in which we can do dialysis, like in methanol poisoning, lithium poisoning, or aspirin poisoning. The drugs in which dialysis is not effective is amphetamines, verapamil, opioids, organophosphorus poisoning, and digoxin poisoning. So there is an important concept in a hypoalbuminemia patient, like in nephrotic syndrome, we have to adjust the acidic drugs. Why? Because acidic drugs bind to albumin. There is not need to adjustment of any basic drug. Only acidic drug need to be adjusted in the nephrotic syndrome patient. Next important concept is plasma half-life. What is half-life? Period in which the plasma concentration in the blood reduced to half of its original value. So the important formula of half-life is 0.693 divided by the constant, which is equal to 0.693 multiplied by volume of distribution divided by clearance. So this is the formula based question asked recently in INICET November exam 2024. Okay, so next topic is zero order versus first order kinetics. So zero order mein the amount of the drug is eliminated per unit time remains constant. While in first order kinetics, F for F, like fraction, constant fraction of the drug is eliminated per unit time. In first order kinetics, the half-life and the clearance both remains constant, while rate of elimination is proportional to the plasma concentration. While in zero order kinetics, half-life is less at low concentration and more at high concentration, so both have a inverse relation. Clearance will be more at low concentration while less at high concentration, and the rate of elimination is not dependent on plasma concentration. Maximum drug follows first order kinetics. Most of the drugs. While zero order kinetics, very few drugs follow zero order kinetics, which include alcohol like ethanol and methanol, while some drugs which are following first order kinetics but at very high concentration, they follow zero order kinetics, which include warfarin, alcohol aspirin, tolbutamide, theophylline, and phenytoin. The mnemonic is watt power. So there is a important example to understand the concept of first order. Initial plasma concentration, let's say it's 100. After 1 hour it becomes 50, after 1 hour 25, then after 1 hour 12.5. So every hour 50% is eliminated. Constant fraction is there. While in zero order kinetics, you can see the initial concentration is 100, then becomes 80, 60, 40, and 20. So at each step, there is subtraction or elimination of 20. So the amount remains constant. Next important concept is the important hormones that bind to the different receptors. So first we'll talk about the intracellular receptor, which includes cytoplasmic and nuclear receptors. So in cytoplasmic we have the glucocorticoids, mineralocorticoids and androgens, while in nuclear receptors there are thyroid hormones, vitamin A and vitamin D, previously asked question. Next, hormones that bind to cell surface receptors, there are G protein coupled receptors, which are GS, which stimulate cyclic AMP like ACTH, CRH, FSH, LH, vasopressin, V2 receptors, and other examples. GI, inhibition of cyclic AMP, which includes catecholamines, acetylcholine, and somatostatin. GQ, which is a secondary messenger, is the phospholipase C. So phospholipase C is IP3-DAG pathway, which includes GnRH, catecholamines, vasopressin, V1 receptor. Remember V1 receptor, vasoconstriction. It falls under IP3-DAG pathway. Gastrin, cholecystokinin, oxytocin, acetylcholine, and via cyclic GMP. Two important examples are the ANP, atrial natriuretic peptide, and nitric oxide, which causes vasodilatation. Tyrosine kinase receptors, important question, many times asked. Through JAK-STAT pathway and kinase pathway, we have the growth hormone, erythropoietin, insulin, leptin, and prolactin. These are all acting via JAK-STAT pathway. And via tyrosine kinase receptors, we have these growth factors like VEGF, FGF, and PDGF. Now we have some discussion of different receptor families. Ligand gated, the first is ligand gated, which includes neuromuscular acetylcholine receptor at neuromuscular junction, GABA receptors, and glutamate receptors in the CNS. G protein coupled receptor, very frequently asked question. G protein coupled receptor include the type of G proteins are GS, that is increasing cyclic AMP, I for inhibitory action, decreases cyclic AMP, and GQ via phospholipase C, which stimulate increase in IP3-DAG pathway. Events that occur during activation of G protein coupled receptor. First, there is binding of the ligand, then there is release of GDP, stimulation of adenyl cyclase, and then hydrolysis of GTP. G protein coupled receptor which are acting via the potassium channels are muscarinic receptors M2, dopamine receptors, serotonin 5-HT1 receptor, alpha 2, and adenosine A1 receptors. Which are acting via calcium channels is angiotensin 1. Rest all is acting via potassium channels. There is a very important receptor family, that is MDR1, multi-drug resistance 1, which is also called as P-glycoprotein. P here stands for permeability. This is a previous question of INICET. Protein involved in the metabolism elimination, and detoxification of the drugs. That is the role of P-glycoprotein or MDR1. MDR1 is a member of ATP binding cassette, that is ABC transporter family, which is subcategory is ABC B1 and CD243. Important concept that increase in P-glycoprotein expression lead to decrease absorption of the drug. Increase in P-glycoprotein expression lead to decrease in the absorption. So main concept is whenever the P-glycoprotein expression is increased, the absorption of drug is decreased. While when there is decrease in the P-glycoprotein, there is increase in the absorption. Drugs which are inhibitors of P-glycoprotein or ABC inhibitors. This is also a PYQ question asked in November 2023 examination. Amiodarone, verapamil, cyclosporin, itraconazole and clarithromycin. Digoxin should never be given with these P-glycoprotein inhibitors, otherwise it will lead to increase in the risk of toxicity. Next concept is therapeutic index. So it indicates the safety level of the drug. The formula is median lethal dose upon median effective dose. LD50 upon ED50. The 50 represents 50% of the individuals. So this is an important graph which can be asked. So there is two drug A and B, and the graph is between the percentage maximal response and via the log dose response. This is the effective dose and this is the lethal dose, and between these two there is a safety margin. Increased therapeutic index represents the safer the drug. Increased therapeutic index means safer level of the drug. Narrow range of therapeutic index means the safety level is very low. Next we have the clinical trials. There are 4 phases of clinical trial. There is also one more phase, phase 0, which is called microdosing, which is not just very important. Phase 1, 10 to 100 number of patients, used in only healthy volunteers. It's an open label study design. It is used only for safety and tolerability profile. Phase 2, done in 50 to 500 patients, randomized and controlled trial. It is used for efficacy and dose ranging for 1 to 2 years duration. Phase 3 is also called as pivotal trial or a multi-site trial, done in approximately 500 to 3000 patients. Randomized and controlled trial or blinded. It is used for therapeutic confirmation and comparison, monitoring of adverse drug reactions. Duration is 3 to 5 years. Phase 4 is the largest, or according to the study, real world patients. It is usually the observational or open label studies. So we have 2 open label studies in phase 1 and phase 4. Post marketing surveillance. In phase 4, we can judge the rare side effects. The duration can be unending after the drug approval. The important drug schedules which are asked in the previous year examinations. Schedule H, the drug which are sold only on prescription. Schedule Y, import and manufacturing of the new drugs. Schedule X, the drug which have abuse liability, for example ketamine and amphetamines. Next topic is Autacoids. First we'll talk about the histamine receptors and their mechanism action. Histamine receptors are 4, which are H1, H2, H3, H4. H1 includes in smooth muscles, endothelium and CNS. It acts via IP3-DAG pathway. H2 in parietal cells, gastric acid secretions via race cyclic AMP. H3 brain, blood vessels which act by decreasing cyclic AMP. H4 receptors, GIT and bone marrow cells. We'll talk about antihistaminics now. First generation and second generation antihistaminic acting on only H1 receptors. Diphenhydramine, promethazine, cyclizine, cyproheptadine, clemastine. These all are first generation antihistaminics. The important thing is they will all cross blood-brain barrier leading to sedative action. Second generation antihistaminics are cetirizine, levocetirizine, loratadine or disloratadine along with fexofenadine. Important antihistaminics, doxylamine, which are used in combination with vitamin B6, especially in morning sickness in pregnancy. Promethazine for allergies and for nausea. Highly sedative action is there for promethazine. Cyproheptadine has also 5-HT blocking properties used in serotonin syndrome. A recent asked in NEET PG 2024 exam. Second generation, cetirizine, which are used in hay fever, allergies, urticarias, atopic dermatitis, and seasonal asthma as an add-on therapy. Antihistaminic, which has a PAF, platelet activation factor antagonist property, is rupatadine. Now we'll move on to H2 antihistaminics, which are used for peptic ulcers and gastroesophageal reflux disease, which includes cimetidine, ranitidine, famotidine, and roxatidine. Now we'll move on to the treatment of migraine. What is migraine basically? Migraine is just a throbbing, pulsatile headache which is limited to the one side, which can be associated with aura or without aura. The attack lasts for 4 to 48 hours. Other symptoms are associated are the photophobia, phonophobia, headache, nausea or vomiting. The drugs for migraine are specific drugs which include triptans and ergotamines. Non-specific drugs are NSAIDs and antiemetics which are used for just mild to moderate migraine. For prophylaxis, the drugs which are used for prophylaxis are beta blockers which include propranolol, calcium channel blockers, tricyclic antidepressant which include amitriptyline, anticonvulsants like valproate or topiramate, and CGRP antagonist, that is calcitonin gene related peptide antagonist which include erinumab. Now for severe migraine, we have drug called triptans. The main mechanism of triptans is it causes vasoconstriction of the blood vessels. 5-HT 1B 1D receptor agonist. It is used mainly in the acute attack of migraine. The drugs which are included in triptans are the sumatriptan, naratriptan, almotriptan, and rizatriptan. So the major side effects of triptans are it causes coronary vasospasm, contraindicated in coronary artery disease patients. The new drug which is now developed for migraine is 5-HT1F receptor agonist, which decreases CGRP, that is lesmiditens. Next class of drug for migraine is ergotamines, which is a partial agonist at 5-HT1B 1D receptors. It causes severe vasoconstriction, so there is very high risk of gangrene on the long-term use of ergotamines. For a parenteral use, we use dihydroergotamines. CGRP antagonist, the drugs included are olisejipant or talakajipant used for prophylaxis. Erinumab is a monoclonal antibody which is given subcutaneously once a month dose. Next topic is eugosinoids, which include prostaglandins, leukotrienes, and PAF, that is platelet activation factor. Now the important flowchart. We have a membrane phospholipids via phospholipase 2, which is a major precursor, which is a very important part, phospholipase A, which help in conversion of membrane phospholipids to arachidonic acid. Now this arachidonic acid is an important precursor for further cyclooxygenase and lipooxygenase pathway. So cyclooxygenase pathway further give rise to prostaglandin PGG2 and PGH2, which further give rise to other prostaglandins and other derivatives like isomerase, which include PGE2, PGD2, and PGF2 alpha, thromboxane synthase, thromboxane A2, further thromboxane B2, prostacyclin synthase, PGI2, that is prostacyclin. Next, we have lipooxygenase pathway, which give rise to leukotrienes. The main leukotrienes mainly are leukotriene B4, leukotriene C4, and leukotriene D4. Cyclooxygenase pathway have two derivatives, COX-1 and COX-2 enzymes. Platelet synthesis, thromboxane A2 is essential, further give rise thromboxane B2. Vascular endothelium, PGI2 is released from vascular endothelium, that is prostacyclin. Lipooxygenase pathway mainly in lungs, WBCs and platelets. Lipooxygenase pathway is also mainly responsible for asthma. That's why in asthma we give 5-LOX inhibitors drugs. Next, it includes effects of prostaglandins on the heart, which include PGE1 agonist, which keep the ductus arteriosus patent, which include alprostadil. Alprostadil is a drug which is also given in erectile dysfunction patients. Next, PGI2, prostacyclin, which is a vasodilator used for treatment of pulmonary hypertension. The drug is iloprost. Now the important table, which includes PGE2, PGF2 alpha, prostacyclin, PGI2, and thromboxane A2. In this, the important things are PGE2 produces vasodilatation, which decreases the BP. It causes dilatation of the bronchus. PGE2 is responsible for decrease in acid secretion. It contracts the longitudinal and relaxes the circular muscles. Next, PGF2 alpha. The main drug which is PGF2 alpha derivative is carboprost, which is mainly used for abortions and postpartum hemorrhage treatment, as it causes contraction and softening of cervix. It is also used for labor induction. It causes constriction, bronchoconstriction, so carboprost drug is contraindicated in asthmatic patient. Prostacyclin PGI2 causes vasodilatation. It has anti-aggregatory effects. It causes dilatation and inhibit histamine release. Thromboxane A2, it causes vasoconstriction. Main action of thromboxane A2 is platelet aggregation and release reaction. It causes uterine contraction as well as it causes vasoconstriction in the kidneys, leading to decrease in GFR. Next class of drug we'll discuss is non-steroidal anti-inflammatory drugs. It includes many subtypes. The class of drugs includes non-selective COX inhibitors like aspirin, propionic acid derivatives, mefenamic acid, pyroxicam, tinoxicam, acetic acid derivative like ketorolac, indomethacin, and pyrrolizone derivatives like phenylbutazone. Other class of drugs are preferential COX-2 inhibitors, which include nimesulide, diclofenac, eclofenac, selective COX-2 inhibitors, celecoxib, pericoxib, etirocoxibs, paracetamol, which is analgesic, antipyretic, but very weak or poor anti-inflammatory action. The important drug is aspirin. The mechanism of action is it is irreversible inactivation of cyclooxygenase pathway. Rest all the drugs causes reversible inhibition of the enzymes, but aspirin causes irreversible inhibition. Aspirin is analgesic, antipyretic, anti-inflammatory as well as antiplatelet effect. At low dose, 70 to 150 milligrams, it inhibits thromboxane A2 and causes antiplatelet effects, which is used in post-MI and stroke patients as a prophylaxis. Aspirin, it lead to respiratory alkalosis in initial state. Later on, it lead to metabolic acidosis. Now some adverse effects of aspirin: gastric mucosal damage and ulceration on a long term use. It causes a very specific Rey syndrome. In children with the viral infections like influenza, they are taken more and more aspirin, leading to further fatty infiltration and encephalopathy. Next important drug is paracetamol. If a large dose is taken of more than 150 mg per kg in pediatric patient or more than 10 grams in adults, it lead to toxicity. The important metabolite responsible for paracetamol toxicity is NAPKI. The glucuronidation capacity is saturated, leading to liver and renal cell necrosis. The most important antidote for a paracetamol poisoning is N-acetylcysteine. We can also go for the gastric lavage. Initial state, we go for gastric lavage if the patient comes early within 4 hours. Further on, we go for N-acetylcysteine. Some selective COX-2 inhibitors which have an advantage of no GI side effects and no antiplatelet effects. But the most important adverse effect of selective COX-2 inhibitors are MI, infarct can be there, stroke, congestive heart failure and hypertension. The most selective COX-2 inhibitor is lumicare-coxib and least selective is celecoxib. The drug which is given parenterally is only one, that is pericoxib. Parenterally, pericoxib. Now we'll discuss two important clinical conditions and their related drugs. Rheumatoid arthritis. The anti-rheumatoid drugs includes first class disease modifying anti-rheumatoid drugs, DMARDs, which are non-biological agents and biological agents. So non-biological agent further includes immunosuppressant. First we give methotrexate as a first line drug, azathioprine, cyclosporin. Other drugs include sulfasalazine, hydroxychloroquine, leflunomide or tofacitinib. Biological agents include TNF alpha inhibitors, the most important, which include etanercept, infliximab and adalimumab. Other agents are anakinra, abatacept and rituximab. Adjuvant drug includes steroids like prednisolone. Methotrexate is an important first-line drug which is given in a rheumatoid arthritis patient, which is a dihydrofolate reductase inhibitor kept. First line DMARD. The important adverse effects are gastric irritation, most common side effect, bone marrow suppression leading to pancytopenia, hepatotoxicity leading to fibrosis and cirrhosis. So regular liver function tests are done in a patient with methotrexate and it's teratogenic drug as well. Important drug for rheumatoid arthritis includes sulfasalazine, which include two subtypes, sulfapyridine and 5-ASA. The 5-aminosalicylic acid derivative, which is used for ulcerative colitis, and sulfapyridone is an active moiety used in rheumatoid arthritis. Leflunomide is a drug which is dihydroorotate dehydrogenase inhibitor. It is contraindicated in pregnancy. The safest drug which can be given in pregnancy for rheumatoid arthritis is hydroxychloroquine. Biological agents includes anakinra, which is interleukin 1 antagonist, and rituximab, which is CD20 antibody antagonist. Other drugs are tocilizumab, which is interleukin 6 inhibitor, and tofacitinib, which is Janus tyrosine kinase inhibitors 1 and 3. Tocilizumab is a previously asked question. Now we'll talk about acute gout and chronic gout. So in acute gout, initially the uric acid may be elevated, and sometimes in some patients also seen that uric acid may be normal in an acute gout patient. So three class of drugs are used. Initially we use NSAIDs followed by glucocorticoids, intra-articular injections, and later on the final drug is colchicine. So NSAIDs which are used in an acute gout patient is naproxen, diclofenac, indomethacin. Most commonly used is indomethacin. Aspirin drug is contraindicated because it causes hyperuricemia. Important drug colchicine, which inhibits, the mechanism is it inhibits granulocyte migration. The side effect is diarrhea and myopathy. It also inhibits mitotic spindle in the neutrophil. That is an anti-mitotic activity. Now in chronic gout patients, we have two classes of drugs, uricosuric drugs and uric acid synthesis inhibitors. Uricosuric drugs are those drugs which will increase the uric acid excretion in the urine, which include probenecid. In probenecid drug, we will advise the patient to take plenty of fluids to prevent the stone formation in the kidneys. Sulfenpyrazone, benzbrominone, which is an important previous year question of INICET, which is acting via suicidal inhibition, and lesinurad, which is urate 1 transporter inhibitor in the kidneys. Uric acid synthesis inhibitors, which includes allopurinol. So, allopurinol is an important drug which is a xanthine oxidase inhibitor. If the patient is allergic to allopurinol, he can use febuzoxate. The important side effects of allopurinol is rashes, fever, the hypersensitivity reactions, and the most severe reaction is Stevens-Johnson syndrome. There is a previously asked question. There is an important drug developed for gout, especially for chronic gout patient. It is pegloticase, which is derived from an important component of RAS-B uricase. So that's it for today. Further parts of pharmacology will be discussed in the further videos. Thank you so much. Please subscribe and share the channel as much as possible. Thank you so much.